by the Southwest Eye Institute. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the students this evening. We have 2 medical students in their 2nd year. We have Aaron Pines and we also have James Fong. This is James's 2nd time on. This is Aaron's 119th time on, we think. We're not sure. But they're going to be answering the phones and taking the questions. And we also want to thank very much all the doctors with the El Paso County Medical Society. They're the ones that bring the show to you each and every month. All of us are volunteers, and they are too. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. Thanks again for joining us. We were just discussing, we haven't had a show about the eyeballs since 2004. So I'm very excited about the show this evening because all of us have issues with our eyes. All of us, 99.9%. My brother has perfect vision and he flies for American Airlines, and that's, I don't know, it makes me mad. But anyway, we have Dr. Mark Ellman is here, and he's an ophthalmologist, and we also have Dr. Javier De La Torre, who is an ophthalmologist. Both are with Southwest Eye Institute. It used to be the institute that Dr. Schuster was with, so we can talk about that too, because he's just an icon that's been around forever and a day.
Well, not affiliated, but when he retired, we took over the Lasik portion of his practice.
There you go.
Thank you for
saying that.
I started the Southwest Eye Institute in 2004, and now we're the largest, most comprehensive eye group in El Paso.
So you've been around since 2004?
Correct.
Okay. That's a lucky year tonight. So, Dr. Ellman, if I can start with you, both of you are ophthalmologists.
Correct.
But as we are speaking this evening, how do I differentiate the two of you when people are asking questions? So what is your specialty in ophthalmology, and what are the questions that you'd like to address this evening?
So Dr. De La Torre and I are both comprehensive ophthalmologists. We treat all parts of the eye, but my focus is on cataract surgery, and Dr. De La Torre's focus is on Lasik and other refractive surgeries.
Okay, great. So I was going to ask you the same thing. So let's throw in the word glaucoma in there somewhere.
So again, glaucoma is one of the diseases that we treat within the range of the eye world, but there is a specific subspecialty. There is a glaucoma subspecialty that you can train on, and we are fortunate to have one glaucoma specialist in town who cooperates a lot with our practice.
Very nice. Love to hear that. I wanted to tell everybody at home that we are streaming live on Facebook, and you'll also be able to see this again on kcustv.org as we get these questions throughout the evening, and then also at the El Paso County Medical site, which is epcms.com. So let's go to, we have a PowerPoint, and if I can ask Mario in the back to cue this up, there is a photograph of the eye. And I'd love to actually start this evening with that. And Dr. De La Torre, I'm going to ask you to kind of start with the general portions of the eye once we get that queued up. And then Dr. Ellman, I'm going to ask you to be a little bit more specific. So as we are looking at it here, what are we going to be talking about tonight? And maybe explain the different areas of the eye that we're going to be discussing.
Absolutely. So I like to explain to the patients that the eye is the fanciest camera ever built. And our eye has 2 lenses. The first is the very front, that is the cornea. Then we have a lens inside the eye called the crystalline lens. So essentially we have a 2-lens camera.
Okay.
Then we have the film of our camera called the retina, and then the USB cable that downloads the picture to the brain, the optic nerve.
Beautifully explained.
So
I like
it works
that.
just exactly like a camera.
Okay.
And so in order for the camera to work well, every single part of the camera needs to be working perfectly. And most of the patients that need glasses, contact lenses, is because the shape of their camera, the shape of the eye, it's one that it doesn't complement each other. The lens and the length of the eye doesn't complement each other. So when the images are formed, they are not falling on focus on the retina. And that's why the patients need glasses. Essentially, add a 3rd lens to their camera to push the image back and forth until the image falls right on top of the retina, and then you can see sharp.
Interesting. So when you're looking at a person like me, I've been wearing eyeglasses. I didn't know I needed eyeglasses until I was in my 20s, and I was in Germany. I'm from Germany. I was driving, my mother was giving me directions, and I couldn't see the signs, and she kept getting mad at me because I would miss the exit. And she literally popped me across the chest with her eyeglasses and said, try these on. And I tried them on. I had no idea that I needed eyeglasses. So on that note, I've changed eyeglasses many times throughout the year. Is that because the eye is changing shapes in, you know, early life, and now I feel like some of my vision's correcting again. Why is that happening?
Very good question. So the typical eye, this is a person that doesn't need glasses. You're born and the prescription typically starts to change. As we grow this way, the eye grows this way, and the prescription changes. And that is a process that is fairly active until about age 18. And at some point around age 18 to 21, when we stop growing this way, our eye stops growing this way. Therefore, the prescription should stabilize. And the typical patient doesn't see a change in their glasses from about 18 to about 45. And then 45 comes.
Right.
And that's when the eye starts to change again, because then the lens inside the eye stops accommodating. The lens inside the eye has the ability to change shape and help us see up close. When that happens, now we need reading glasses. That's why somebody that never needed glasses, at 45, they have to go to the dollar store and find those reading glasses that are there.
Yep.
And then that age-related changes continue to settle, and then 60, 65, we start to see early changes of the lens where the cataract starts to develop, and then the prescription changes again. So there is a normal age-related change that will happen, that will change your prescription throughout your life. Now, if you're born with a longer than normal eye, myopia, shorter than normal eye, hyperopia, or with a cornea that is more football-shaped, that's astigmatism, then you will have to do glasses, and that prescription most likely will change actively until about age 18, and then the prescription should stabilize from 18 to 45, then starts to change again, and then further on when cataract develops, changes one more time. So age-related changes on top of glasses prescription, that's why that active change in the glasses throughout your life.
That is so beautifully explained, because I'm 51 and I felt like a couple of years ago, so I'm that person that buys cheap eyeglasses because just like right here, I'll put them down somewhere. What did I ask you actually 3 minutes before we went on the air?
Yeah.
What did I ask
where
you?
are my glasses?
Where are my glasses? Oh, there they are. So I've got glasses everywhere, but then I start wearing my glasses and they're not working anymore. Yeah. So that is that time in this life. Correct. So that is lenses. I'd like to go to Dr. Elman for a moment and talk about some of the other issues with the eye. So we saw what the eye is and the different parts of the eye, and you were talking about, well, let me talk about some more that are specific issues with the eyes. Maybe we can start on that.
Correct. If we could put that slide back up, I'd like to point out where the lens is in the eye, if it's possible.
Okay.
So right behind the iris, the colored part of the eye, sits your lens. You could see it there. So starting from the left, the first thing is the cornea. Behind that is the blue thing on this picture, the iris, and behind that is the lens. So you're born with a lens inside your eye, and then as you age, as a natural process, that lens becomes cloudy. That is called a cataract. Cataract surgery to remove that dirty lens is actually the #1 surgery performed in the United States.
Is it really?
It is.
Wow.
This is another view of cataract, so we could see a clear lens on the left and then a cloudy lens on the right. So imagine, just like if the windshield of your car started to become cloudy, you wouldn't see very well. If the lens inside your eye is cloudy, you would not see very well.
What causes the cloudiness? Is it protein buildup? Is it
changes in the proteins inside the lens?
Okay.
So we see it as a normal aging change in just about everybody. Everybody with time will develop cataracts. We do also see it sometimes related to medications, especially steroid medications, and we could also see it related to trauma. And then very rarely, luckily, you can sometimes be born with cataracts or develop it at a very young age. But typically cataracts is something we see in older population.
Okay. Are there people that, like you said, some people are just naturally at higher risk for that? It could be just something in their system. Like if my grandmother had cataracts, would that mean that I'm more prone to have cataracts?
Everybody's grandmother had cataracts.
Okay, like you said, everybody, if they
really
live long enough will
common.
get cataracts.
It's really, does it bother you enough in your lifetime that you're going to end up doing something about it? For most people it is. And the nice thing is the technology that we have today, cataract surgery takes about 4 or 5 minutes. So it's
4 or 5 minutes?
It's quick, yep.
So could you, I know we don't have a video or anything, but could you kind of walk me through what cataract surgery would be?
Sure. So you come
it's like you're trying to sell this to me. Say, hey, you know what? This is what you're going to go through, and I want to be prepared but not scared going in it. That's how I want you to explain
Excellent.
it. Okay.
So typically in our facility, we have our own surgery center that we dedicate 100% to the eyes. It's adjacent to our east side office. So the patient, you would show up at our surgery center on the day of surgery, you would register, you would go into a bed. You actually don't have to even change your clothes. You can usually leave your clothes on. We go ahead, we put some drops to dilate your pupils. The anesthesiologist gives you a pill under your tongue to relax you a little bit. We usually don't start an IV at our facility. And then we roll you into either the operating room or to the laser first if you're getting laser-based cataract surgery. I then, just some numbing drops on the eye, make very small incisions that you don't feel. You're awake, we're talking. I usually tell you a couple of jokes to make it go by faster.
Oh, I want to hear some of those later too, by the way.
If we have time.
Yes, we'll have time.
Take out the dirty, so I use an ultrasonic vacuum. It's very small. My biggest incision is 2 millimeters. Take out the dirty lens, and then through that same opening, I put an artificial lens that's clear in its place.
Now, I'm going to ask a question just as it comes up. When you say you take out the dirty lens, is it just floating in there? I mean, I'm embarrassed because I don't know, but how is the lens attached to my eye right now to where it's not coming out? I mean, there's film, there's...
Right, so your eye is enclosed inside. And behind the iris sits the lens, and it's attached by these little strings called zonules. And so we take out we make an opening into the front of the lens, and then take out the contents, but actually leave the outer shell in place. This is all inside the eye.
Okay.
And then I put the new lens inside that outer shell, and that's how I'm able to do it without using any stitches or glue or anything like that. It just sits within that shell inside the eye. And then
how does it not move from there?
Because the original capsule of the original lens is there, still being held by those strings, and they're still all in place.
Okay.
So we're taking out the contents of the lens, but leaving the outer portion in place that's still being held in place.
Okay. So now I've had my 5-minute surgery. What happens now?
So you go to recovery, have a little bit of juice, and maybe a little snack, and a few minutes later you can go home. We typically tell patients the first day, go home, rest, watch TV. You can eat. We have patients that come from out of town. They sometimes go shopping and stuff like that, but we generally rest.
That same day?
They do, yep.
Really?
Some people even travel home. We get patients that come from sometimes a couple hours. Some people fly in to get surgery. So some people do travel. Most people stay overnight and leave the next day. And so I recommend you relax the first day. And we tell patients the next day they can go back to most normal activities. The only thing we ask is nothing very strenuous for the first week, so no really heavy exercise or construction or bungee jumping or something crazy like that. And then no swimming for a couple of weeks because pool water tends to be pretty dirty. But people can go back to life pretty quickly. We try not to give too many restrictions. We've done, between myself and my partners, we've done probably 40, 50,000 cataracts, and we've never had somebody mess up their eye after surgery. So the chance of that happening is so slim. So we don't put too many restrictions on people. We want them to get back to their lives pretty quickly.
So here's, and again, pardon my ignorance, because it has been since 2004 since I've been educated about this, and things have changed a lot. Now you have the new lens from a cataract surgery. That new lens, is that a lens that you were talking about earlier, Dr. De La Torre, that might be, like the shape is a little bit different? Are you able to correct vision by doing cataract surgery?
That's one of the exciting things. So cataract surgery can solve several problems. First, if you have a cloudy lens, we get that cloudiness out, so you're going to see better. But now we can also correct your refractive error. So if you're younger and you want to get rid of glasses, you could see Dr. De La Torre. He could do Lasik or something similar on you to get rid of glasses with a laser. Or if you're older, we could do it with cataract surgery or something in between. And the lens we put in is measured for your eye to give you the best possible visual outcome. So most patients can eliminate at least distance eyeglasses after the cataract surgery. If they have astigmatism, if they have an abnormal shape to the cornea, the front of the eye, we can correct that at the time of the surgery, which would also reduce the dependency on glasses. And then there's multifocal lenses. There's lenses that focus distance and near at the same time. And those patients get the greatest spectacal independence because they're able to see at distance and at near, oftentimes without the use of glasses, except very rarely.
And that's multifocal.
So focusing in both spots compared to a regular lens that we put in called a monofocal, which would be focused at one point. And even with that, we have flexibility. Most patients get both eyes aimed for distance vision.
Right.
And if they're lucky and things go as planned, they're just using over-the-counter reading glasses.
Right.
Some people want both eyes for reading. Some people say, I don't drive that much. I use my cell phone, my iPad, my laptop. My mother, I did her surgery about 2 years ago, and she's a homebody, and she likes her computer and laptop and her iPad and all that stuff. So I made her for near, so she rarely uses glasses, just when she's doing, driving where she's not familiar, things like that. So we can play around with different settings, even with just a lens aimed at one point in space.
And Dr. Toller, you had something to add.
That is a message that we try to get across daily in the office. The old mentality of looking at the cataract as something that you would just watch and wait until you get severely affected to then do surgery. We're trying to phase away from that mentality and educate our patients that cataract surgery, with the new technology, with the experience of our surgeons, with the equipment that we've invested, is a very safe and accurate surgery that is as reliable and accurate as Lasik it is. So it has the same power as Lasik in helping patients not only get rid of the cataract, but also get rid of part of not all of their glasses. So we are trying to move away from the mentality of watch and wait. Let's get the cataract ripe. That's not the way that we approach cataract surgery anymore. We want the patients to come in and we ask them, are you being affected in any way in your daily activities? And if there's activities that they could do before because they could see well and now they stop doing because they can't see well, that is an indication to do cataract surgery. We no longer have to wait until their cataracts are ripe.
Okay, so when you say ripe, and I'm thinking two different things here. I'm nearsighted, so I need eyeglasses to see far away, but I don't have that cloudiness yet. So when you're saying, and let's say it's old school, let's say it's someone who hasn't heard about this since 2004 like me.
Correct.
Ripe would mean, do you start, how's the question? How do you know when you start seeing cloudy if it just comes on so gradually and so slowly that you don't even realize that's happening?
Our patients, so our patients typically would like to, they usually start seeing night vision changes. So difficulty driving at night, having glaring halos from upcoming car street lights. They also confess that they have difficulty reading, that they need more light to read, or that the small print, even with the new prescription that they got, the new stronger prescription, they still have difficulty reading that small print. Usually those are the early signs that the cataract is starting to affect your vision.
And when they come to you, you were talking about screenings earlier too. How does one screen for cataracts? Is there a certain amount of cloudiness that is preferred before surgery, or how does, say someone didn't know, again, that they had a cataract beginning, and they're going to a screening that you happen to have somewhere.
Correct.
What does a screening do?
So if we do a health screening where we're checking their vision and just see what their level of vision is, some people do have decreased vision, they don't even realize it. But most people, like Dr. Del Toro mentioned, have a complaint. So they come to us because they say, I'm having trouble driving at night now, what's going on with my eyes? And we look in and they have a cataract. What Dr. Del Toro referenced, about it being ripe, years ago when the technology wasn't the same, the cataract surgery was much more invasive. So they waited until the cataract was pretty advanced. Medicare actually had set guidelines that it had to be below a certain vision level in the past. That's gone. Medicare no longer says you have to be below a certain vision. They say you have to have visual complaints. So if somebody has visual complaints, if their vision is affecting their ability to live their lives, then it's justifiable to do cataract surgery if they have a cataract.
Say that again, because that's a big question that we get, is insurance, Medicare, etc. So whatever it is that you can say to help the audience to ask these questions, say it again.
Sure. So, well, like I mentioned, cataract surgery is the #1 surgery performed in the United States. It's a #1 line item for Medicare. So most patients, in Medicare age get cataract surgery, and they get it twice, once in each eye.
Okay.
Medicare and other insurances do cover cataract surgery. There's occasionally some out of pocket to the patient, but the majority of it's covered by the insurance. And then there are premium options, like we talked about before, multifocal, astigmatism correction. Those are in addition, not covered by insurance, but those are optional items.
Okay. Nicely said, and we've got the camera back on. Dr. De La Torre, I'd like to talk about me being a baby. Again, I'm 51. LASIK is all around. Everybody talks about it. I'm still a person that I will take my eyeglasses because I cannot stick my finger in my eye to put an eye contact on. It drives me insane. And I'll wear them maybe twice a month. If I have to MC something and I have to read and look far away, I'll put one eye contact in. Yeah. So I'm that girl, and you're the LASIK guy. So let's talk about when people come to you and they're questioning, am I, #1, a candidate? First, let's talk about if you are physically a candidate, because you talked about that earlier. Right. And #2, what are some of the most common questions that patients ask you on whether or not they want to have the surgery?
Sure, absolutely. So first of all, in terms of being a candidate, when you come in, we have machines that we have purchased that help us know that the eye is healthy and ready. We look at the corneal thickness. There's a certain amount of cornea that you have to have in place in order for us to do LASIK. Also the shape of your cornea, make sure that the shape is the correct shape. And also just the general health of the eye and also the general health of the patient. You have to have a healthy eye and you have to be healthy in order to get LASIK. So after we rule out, make sure that there is no contraindications, then we can proceed. LASIK surgery, I like to tell patients that the earlier you get to the LASIK party, the better. And this party starts at 18. So it's FDA approved for
really?
18 and
Okay.
above.
Okay.
And so we like to get to the patients, the earlier the better. Now, there are a lot of the patients that come to us usually around age 40. And why is that? Because typically at that age, you are more financially set, things are already taken care of, and then you have that extra income that you feel like you can invest in yourself. And at that time also, you start to struggle with your near vision.
Right.
And everything, it's a perfect storm coming together, and then patients start to show up. So the questions that I usually get is, how long is it going to last? Well, the younger you get to it, the longer it lasts. And so a patient that comes to me at age 20 and gets LASIK, now they have 25 years of independence of glasses.
Right.
Because their distance will be past 45, but they'll lose their near at 45. So now I tell them, hey, you come at 20, you have 25 years of independence. But if you come at 40, now you have 5 years of independence of glasses. So the younger you get to the LASIK party, the better it is. Now, a lot of the patients that come at 45 and they want independence of glasses, then we have to work around the presbyopia, the lack of near vision. So we offer an option, like you mentioned, one eye distance, one eye near. That's called a monovision. So patient come in, part of the candidacy, we determine which is the dominant eye. And typically the dominant eye is the one that you use when you aim with the camera or when you aim with your weapon. And that's going to be our distance eye. And then the near eye will set up to whatever is that you enjoy doing. If it's computer or if it's very fine print reading, then we can adjust the near vision for that specific task that you like to do. And so there are options, but we have to tailor those options depending on what time the patient shows up in their life. Not the same thing, somebody that it's working, that the one that is retired.
Right.
And so we take in consideration all those things, and then we come up with a surgical plan that better fits that patient.
That makes perfect sense. And when you said earlier, I thought, well, why? But that, again, you've got that kind of set lens shape for that 20, 25 years.
Correct.
All right, that's good to know. Both of my kids wear eyeglasses. One's 16 and one's 21.
Yes.
So we'll talk about that. I want to talk a little bit, Dr. Ellman, about age and cataracts. And we already talked about that it kind of happens differently with every person. But let's talk about a general age. So we're talking about eye shape is changing around 45-ish. Cataracts in, let's say, the normal population. I know there's side, but in general, when does cataracts start forming so that if people are thinking, if there's a screening, maybe I should go because I'm kind of in that age group?
Well, that's kind of the two parts to that question. You know, one part that's probably more important is everybody should be getting a comprehensive eye exam. The American Academy of Ophthalmology says at age 40, everybody should get one, and at age 60, it should be every year, and then it's about every 2 years in between. So it's very important to get a comprehensive eye exam because you can find things that you don't know that you have. Cataracts is just one example, but other problems in the eye, such as glaucoma, macular degeneration, diabetic changes in the eyes, which is important because we're in National Diabetes Month right now.
Right.
So getting a comprehensive eye exam should be part of your routine general care that you're getting, even if you're not having any eye problems.
Now, I'm going to stop you. We're still going to go to that second part of the question because this is what I was going to ask in the beginning of the show and I didn't. Talk about when you're saying a comprehensive eye exam, there is ophthalmology and there's optometry. So I'd love for you to really separate those two for our audience because going to an optometrist is very different than going to an ophthalmologist. So when you're saying comprehensive ophthalmologist, what does that mean compared to optometrist?
Well, sometimes.
Okay.
It's really a comprehensive eye examination. So yes, there's optometrists and there's ophthalmologists. At the Southwest Eye Institute, we have both.
Okay.
But our optometrists are 100% focused on medical care of the eyes. So what you want to make sure that you're getting with a comprehensive eye exam, it should not be just an eyeglass prescription. That could be part of it. But you want to make sure that you're getting a dilated eye exam. You're getting drops in your eyes to make the black part, the pupil, big. Checking the health of the back of the eye, make sure everything looks healthy back there. That's part of a comprehensive eye examination. And that can be performed by an ophthalmologist or an optometrist.
Okay. Nicely said. I have a question here from the... They're coming in. Did I tell you that this was going to be a popular show? They're coming in. So the big question, before we go any further, please announce how patients can get in contact with the doctors. So this is the Southwest Eye Institute. Might you have a phone number memorized?
Yes.
Okay, go ahead. What is your phone number?
So our main phone number, we've got two primary locations in El
Okay.
Paso, east and west side. The east side is off of Lee Trevino behind the Golden Corral. The west side is on Wrestler by Whole Foods.
Okay.
And then we also have our Lasik Center, which is where Dr. Schuster used to be located across
Gotcha.
from Sierra Medical Center.
Okay.
They all go to the same phone number.
Oh, good.
It's 227-2020.
Okay.
And I think we're going to be showing that.
2020. How perfect is that?
And
I
then we
love
have
that.
our website, which they can go to. An easier one to remember is eyesvip.com.
Okay.
So that's EYESVIP.com.
And we'll say that again before the end of the program.
And if you forget, it's all southwesteye.com, takes you to the same place.
Takes you the same place. I love it.
Or forget the I, you go to the airline.
Or
Southwest.com, you go to the airline. Southwest Eye comes to us.
take a trip and then come get your eyes, or take a trip to get your eye surgery. I'm going to go ahead and go with some of the questions here from the audience. I'm reading these cold, but we're getting them everywhere. So, question here from the audience: how would cataract surgery be different for someone who has had RK LASIK and astigmatism? Question from the audience. Who wants to take that one?
Great question.
That's a great question.
Okay, Dr. Delatorre, we'll
I
start
would love
with you.
to answer that because this is one of the things that separate us from other places where you get cataract surgery. Again, every place should know, and you want to make sure that you inform your cataract surgeon that you had some prior refractive surgery, RK, PRK, or LASIK. But we have acquired and invested in technology that help us, even if the patient forgot to tell us that these machines are able to measure the eye, and we can identify those patients that had prior surgery. It is important to know that information because the cornea, because has been reshaped by these surgeries, it can fool the machines. The traditional machines that measure for the lens that goes inside the eye can get fooled. And then if you don't disclose that you had surgery at the time of cataract surgery, you can get the wrong lens. So now we've invested in technology, including one that we're the only ones that have in the region. It's called the Aura machine that goes hooked to our microscope. So our cataract surgeons, at the time of surgery, after they remove the cataract, they can turn on the machine and measure the eye accurately and determine what is the true prescription and the true shape of the eye, so the lens that goes is personalized for that patient. So it is an amazing technology, and I think that patients that had surgery, again, as long as you disclose to your cataract surgeon that you had prior surgery, that should be taken care of. But again, we've invested in this great technology that helps patients get the best lens for their eyes at the time of surgery.
Beautiful. And I just got a note from the guys in the back that all the information is on screen for
Except I lied to you.
You lied to me?
Yeah.
Did you give me a wrong number?
I did. The 2020
Dang.
number is new for us. I have our old number memorized.
Oh, okay.
It's 267-2020.
Okay, 267-2020. No,
that.
it's all good.
People
You
trust
know?
me to do cataract surgery. It's pretty amazing.
267. Hey, that's my birthday, February 1967. I tell everybody how old I am on the show, and it's like, why do I do that? Because there's a frame of reference. And so I think that's very important. And there's the number. Oh, look at you guys are
got it
fast.
right.
So Mario and the team, way to go. That's all the behind the scenes guys. I need to have you guys all come on stage one day and go through this. So another question here from the audience, and it has to do a little bit with macular degeneration. We have not touched base on this, so I do want to touch base on this a bit. A caller would like to hear a little bit about macular degeneration and what are some treatment options. Maybe we can talk about first just what it is, and who would like to take that? Just throwing that out.
Dr. Elman.
Okay, Dr. Elman.
So macular degeneration is another, unfortunately, fairly common aging change, but unlike cataract surgery, it's not as easily fixed.
Okay.
So the macula is the center part of the retina. Dr. Delatorre referenced the film of the eye, the retina. Right in the middle is the macula. Your sharp vision is on your macula. So you're looking at me primarily with your macula right now. As an aging change, or for other reasons, but usually aging, that macula can start to degenerate, and we have macular degeneration. And sometimes it's not bad, sometimes it is bad. There's two types called dry and wet, and it's probably beyond the scope of this show. But when you get to certain types, there are medications that can treat it. A retina specialist is usually the one that does that, and he puts medication into the eye to help reduce the changes that are happening in the eye.
Okay.
The other thing
How does the medication go into the eye? Is it with a shot?
It is a shot.
Is it really?
It sounds really bad, but it's actually not.
Okay.
So it's done in the office. There's patients that get shots every month by
In
the
the
retina
eye?
specialist. Into the eye, in the office. Takes seconds, and it really doesn't hurt, but it sounds like it sounds bad. The other thing we should bring up is nutrition for the eye.
Absolutely,
because
yes.
there have been a couple of really big studies related to nutrition for macular degeneration. I actually created an eye vitamin to reduce the risk of macular degeneration. It's called Vision Protect. And the big study, the age-related eye disease study that we put into that supplement, showed that a certain mixture of vitamins can actually slow the progression of macular degeneration. There was another big study that came out that showed that vitamins B6, B12, and folate can slow the onset of macular degeneration. So there is some potential things that you can do to either slow the onset or slow the progression of macular degeneration with natural supplements.
Okay.
But again, you still need a comprehensive eye exam with dilation, like we talked about, and if you have it, and possibly treat it, with a retina
This is
specialist.
that perfect time to let people know in the audience, again, that this is streaming live on Facebook, but you can also come to it again because you're saying a lot of really good things, and sometimes we miss it when we're watching. So again, Facebook, we're streaming live right now. Also, just find the El Paso Physician and or KCOS. You can also see the show again on kcostv.org. Just go to watch and find the programs because this is good stuff. Another question here from the audience. Man, I feel like you've had too many turns, but... can someone who has had cataract surgery 7 years ago now wear contacts? Question from the audience. And since you're cataract, Dr. Del Torre, would you like to
Dr.
take
Del
that?
Torre answer
Excellent.
that one.
Okay.
So yes, they can use contact lenses, and the idea behind contact lenses is to fix whatever residual prescription was not addressed with cataract surgery. In the same token, we can do the same thing with laser surgery. So we could do a touch-up, Lasik or PRK, after cataract surgery if there's any residual prescription that was not addressed at the time of cataract surgery. So we do that often, where a patient, we try to get them off off glasses after cataract surgery, and they have a small residual prescription. So then I take over after they are done with Dr. Ellman, they come to me, and then I use the laser to erase whatever residual prescription. So yes, you can use contact lenses, but think of the patient that after cataract surgery using contact lenses, usually it's going to be an older patient. Contact lenses at that point in their life, again, used correctly is safe, but we have the technology to also get rid of whatever prescription they were on contacts with the laser after cataract surgery.
Right. Beautifully explained. Okay. Again, I'm embarrassed, but at the same time I need to ask, and I'm going back to my grandmother who's been gone 25 years. It wasn't cataracts, but she had her lens taken out and had a new lens put on. What other condition would have, again, this is 25 years ago, so it would have been 30 years ago, and she had it done in Germany. What would that have been?
It would have been cataracts.
It would have been cataracts.
Yeah. Now, today, what they didn't do back then, we have something called refractive lens exchange.
Okay.
So it's basically early cataract surgery where we take out their lens that doesn't have a cataract and basically do cataract surgery. And we don't do that too often, but that's for the patient that kind of falls between the areas for me and Dr. Del Torre. So they're kind of a little bit, they don't fit for laser, and they don't have cataracts yet, but they want to get the benefit of cataract surgery. They can get refractive lens exchange. But I don't think your grandmother had that. She probably had cataract surgery.
I've always been curious because I specifically asked, anyway, that's good to know.
Yeah.
What made me ask that question is this next question from the audience. It's a big one. A patient has had their lens removed and not replaced in their left eye. Their cornea was replaced with an external lens due to rejected corneal grafts, and their vision is poor. Would it improve if their lens was replaced? Is that possible? Specific question from the audience. Dr. Del Torre?
So, again, using the example of how the eye works, there's the two lenses. So the
If
first,
we're able to put up that eye.
yeah. So the first
again,
lens
that'd be
is the
great.
cornea.
Okay.
And in order for the camera to work well, both lenses have to be working together. So if the first lens was affected, got cloudy, the cornea is cloudy and needed a corneal transplant, then that needs to be addressed in order for that eye to be able to see. So in the scenario that they're asking the question, if you just place a lens inside the eye doesn't have a lens, now you place one, but you don't fix the cornea is still cloudy, the camera won't work. So both have to be complementing each other. So you would have to address both the cornea that is cloudy, maybe a repeat corneal transplant, and add a lens inside the eye. And now the camera will have two lenses, and then the light will be able to focus, and the eye will work.
Beautiful. Okay. Wow. Another caller, this one's about glaucoma. So a caller would like to hear a little bit more about glaucoma, and they specifically would like to know the difference between open and closed angle glaucoma.
So,
okay.
The eye is a drainage system, and I like to explain it to the patients just like pure plumbing. There's a faucet and there's a drain. And the faucet inside the eye is the ciliary body and produces the fluid that is inside the eye. It's called the aqueous. And then we have our drainage system. It's called the trabecular meshwork. And when you have open angle glaucoma, the drainage is wide open, but yet the drainage system, the plumbing, is not working and the pressure is building inside the eye. And so typically it's because the faucet is turned too much and the water, the aqueous, is too much, and the balance between the water production, aqueous, and the drainage is not working well. And patients, despite having an open angle, there's an intrinsic blockage within their trabecular meshwork. Pressure starts to rise up. This patient typically has a pressure that is not high to cause pain or discomfort. That's why it's called the silent thief of sight. Patients, normal pressure should be 10 to 20, and the typical glaucoma patient will have a pressure of 23, 24. But that 23, 24 for decades will start to cause damage, and this damage is on the optic nerve, the USB cable of the camera. And the USB cable starts to lose vision. And the loss of vision is from outside in. And they typically describe it as tunnel vision. So the patient will lose vision in their periphery. So patients show up, and when already they come to us, it's too late at times. Pressure is elevated, they've lost a lot of vision, and it's vision, unfortunately, that cannot return. When it comes to narrow angle, typically this is going to be a patient that is farsighted. They have a smaller than normal eye. And because they are farsighted, already they're born with an angle that is fairly narrow. And now age-related changes start to settle, and the lens starts to grow behind, pushes the iris even more forward, and now the patients are at risk of narrow angle or close angle glaucoma. That type of scenario, it's going to be a pressure that is much higher, very acute setting, and the patients will have nausea, vomiting, a pain in and around the eye gets red and the cornea gets cloudy, and that is considered an eye emergency. And the patients need emergency treatment, medications, sometimes surgery to fix that acute angle attack. So one, it's very low grade onset, the other one is very acute onset, and again, the risk factors vary. Open angle is usually African American. Hispanics were at risk of open angle. There's family history. And the close angle is typically going to be your small hyperopic eye that's going to be at higher risk of acute angle closure.
This is so much information. Yes, Dr. Ellman?
I want to throw something, because we got sidetracked before. You asked about the benefits of cataract surgery.
Yes.
And we said there's typically several. You know, one of them is getting rid of the cloudy lens. One of them is possibly reducing your dependence on glasses. And one of them is actually helping with glaucoma. So high eye pressure in the eye, cataract surgery itself actually lowers the eye pressure. And then if somebody needs a little bit more, we can put in a tiny microscopic stent called an eye stent at the time of the cataract surgery. It adds less than a minute to the time of the case. We put in this little microscopic stent into the trabecular meshwork that Dr. Del Torre mentioned, the drainage part of the eye. That helps lower the eye pressure even more. So a lot of patients are seeing better without glasses and stopping their glaucoma drops. So it's kind of a win all around. If you have the narrow angle type of glaucoma, or you're starting to narrow, one of the possible treatments for that also is cataract surgery, because once you remove that lens, which is pushing that iris forward, that brings things back into place and prevents that from becoming a problem in the future.
So it just seems like there's so many residual benefits to doing all of this.
There are. Now, of course, every surgery has potential risks.
Of course, yeah.
But the risks, thank God, are very small, especially in experienced hands. The benefits can be huge.
I know we have less than 20 minutes, because I was shown the 20-minute sign a couple minutes ago, and I have a ton of questions. I'm going to start firing questions at you. Answer them quick. Some of them might be weird. Question: is there a way to surgically realign eyes? I know it's not really within our topic this evening, but Dr. Del Torre?
Yes, there is. So
Okay.
when the eyes misalign, it's called strabismus, and strabismus surgery is one of the surgeries that are commonly performed. Typically, it's going to be a patient that is young, that are born with the eye crossed in or out, and strabismus surgery can be performed. It sometimes happens as an adult, and so yes, the eyes can be misaligned, and we can align them with surgery that manipulates the position of the muscles that
Okay.
move the eye, and by changing the position of the muscles, you can align the eyes.
Nice. Question here from the audience too. Can someone with only one eye have LASIK surgery? And maybe that's when you were talking about candidates earlier. Is that an issue one way or the other?
It's not a complete contraindication, but when a patient comes with just one eye, monocular conditions, we want to have a really good reason for that patient to have LASIK. LASIK is very safe, but like Dr. Ahmed said, every surgery has a risk. So we want to make sure that the eye is healthy and that there's good reasons to undergo surgery, but having one eye is not a complete contraindication for LASIK.
Okay. Nice to know.
Nor cataract surgery.
Nice you said. Okay.
Yeah, a lot of
right.
one-eyed patients develop cataracts. You know, obviously you have to take that risk into consideration. You're operating on the only eye.
Right.
But patients tend to do very well. Risk of complications very low.
Right.
And so, you know, let them maximize the benefit of that one eye for the rest of their life.
Makes perfect sense. I've never heard this question before, but are sunglasses beneficial or harmful? I always thought that they were beneficial. Question from the audience, are transition lenses better? I've never heard that before. If we want to skip it, we can skip it because we have very little time. But go ahead.
UV protection is good for the eyes. Good
There
for
you
macular
go.
degeneration, good for cataracts. So sunglasses are good. They also, provides you some protection when you're out there if something flies up in your eye or something like that. So I
Nicely
would not say
said.
sunglasses are ever bad.
I think so, too.
Sunglasses versus transitions, I'm not an expert in that, but I don't think there's a big difference.
Yeah. My eyes start crying if I don't have sunglasses on when I'm outside. Question here from the audience. I love this one. Are you taking new patients, and do you accept Medicare? Yes and yes.
Yes
So
and yes.
this will be, again, the Southwest Eye Institute. The telephone number is 267-2020. Just think of 2020 vision. And then eyesvip.com is a good website to go to. So yes and yes. I like that one. That was easy. I'm going to read this cold. I'm going to have to spell something for you. A man has had a recurring and painless style, and I'm going to say Chalazion? Chalazion, thank you.
You're welcome.
For the past month. First of all, what is that? And what can he do, Dr. Delatorre?
He treats those in our practice.
I love your smile and nod like, I got this.
So yeah, bread and butter ophthalmology. We have oil glands around our lashes. We have hundreds of them, upper and lower lids. And when these glands get blocked, that's when bacteria take advantage. And when there's an acute infection, that's called a sty. And the sty, we typically treat with antibiotics. But one thing that we encourage is warm compresses and massages to those glands. The opposite, you would think naturally that if it's hot and tender, you would put cold. But for the eye, it's better to use warm compresses. So that's how we treat usually styes. But when that sty never drains and that sty stays there and that blocked gland is continuing to accumulate its residues, that turns into a chalazion. The chalazion is just a chronic block gland.
Gotcha.
It's just block oil that is not going anywhere. And it becomes not only indurated, but patients feel a bump. It can sometimes push on the eye, cause blurry vision by inducing astigmatism that wasn't there. And so those are the indications to then do a minor procedure that we do very often in the office to drain those chalazions.
I've had both of those conditions for only a couple of days, which is nice. And what causes, I guess, just dirt in the eyes or...
Yes, and so one thing that prevents both of them, it's eyelid hygiene. And one thing we recommend, it's cleaning your eyelids and your lashes, especially if you've been outside working in the yard and on dusty, windy days. You want to make sure that you clean your lashes because that's where these oil glands are located. And once they get blocked, that's when styes and chalazions. One very simple solution is baby shampoo. That doesn't sting, it's tear-free. That's why I use it in babies. They get it in the eyes and they don't cry. Your eyes won't cry if they get baby shampoo. And you can use a warm cloth, scrub your lashes, and that will prevent styes and chalazions. And you can incorporate it in your routine of taking a shower.
Very nice. I still use baby soap on my face. I mean, it's honestly, I ran out of soap when my child was born, and that was what was in the baby basket. Recovering after an eye stroke, question from the audience. Throwing that out there. I don't know what an eye stroke is.
So they're probably referring to an artery or vein occlusion of the eye.
Okay.
And recovery can be very variable. That's when one of the arteries or the veins in the back of the eye, the retina, the film, can get an occlusion. And the course of that is different for every patient.
Okay, gotcha. I still have questions, but we're kind of at that mark. I really want to stop the questions for a minute because there's so much. And I'm going to start with Dr. Della Torre. Is there something that we have not talked about yet this evening, or something you really want to expand on before the end of the show? Because sometimes the show's over and you're like, man, I didn't get to say A, B, and C.
Didn't you have to invite us back?
Yeah, exactly. Would you please? Well, I'm curious. I'd like to know all kinds of stuff.
Well, I would like to, in regards to laser vision correction, it is a very safe surgery that is not for everybody. That's why you want to go to a place that they can make sure that you're a good candidate. And if you're a good candidate, I always tell the patients, done correctly, done for the right reasons, done in a healthy eye, in a healthy patient, is an absolute life changer. I had this surgery myself 10 years ago, and that's why I'm a big advocate. I always said that if I'm going to do this surgery, I have to do it myself. And I had it done, and from then on, I've been a big advocate. And so once you're a good candidate, you're going to have most likely success. Now, I just want to make sure patients understand all these surgeries, they have the risk, and you have to balance those and your activities of daily living, and you want to make sure that you ask all the questions and that those are answered. And the best way is to meet your surgeon on that day and make sure that they're answered before you proceed with any of these procedures, because like any surgery, there's risk.
There's risk. And I like to say, always a conversation. You know, meet with them before the day even. That would be me. I would totally do that. So, Dr. Ellman, anything that we haven't discussed or something that you really want to get across? We still have some questions, but this is that time.
I think we talked pretty decently about cataracts and cataract surgery. You know, I think that a lot of patients are scared to come to an eye doctor. I've had patients tell me that they think that we're going to take the eyeball out to examine it. We don't do that.
Take the eyeball out to
examine it.
No.
So, you know, most important point, which we already talked about before, you know, everybody should be getting comprehensive dilated eye examinations. And then with this being National Diabetic Month, it's also National Eye Disease Awareness Month. And I saw a statistic the other day that was worrisome, and it said that 60% of diabetics don't get exams at least once a year. So if you have diabetes and you have not had an eye exam in at least a year, you need to get an eye exam. Dilation, like we talked about before.
And we talked a little bit about it earlier, but in case you're tuning in, what are the extra risk factors when you have diabetes?
So diabetes can affect all the small blood vessels in the body. So the eyes, the kidneys, the toes, those tend to get what gets affected first. So you can start to have bleeding inside the eye and different things that at first might not have any signs or symptoms. So you feel fine, but the diabetes is causing damage, and it can get to the point that can start affecting your vision. So we look in there, we make sure that you don't have any changes. If you do, we can either monitor it, or if needs be, it can be treated. Okay, nice. The other thing I'll bring up is, you know, if there are more questions we don't get to, we do have a Facebook page at Southwest Eye. People can private message us or post on our Facebook page. We'd be happy to respond to messages. If they don't have that, they could always call the office phone number, the 267-2020, and we'd be happy to take calls from anybody for questions that we didn't get to answer tonight.
Nicely said. Again, for Facebook, Southwest Eye, you can go there. Again, you can look up El Paso Physician and or KCOS and find the show again. Question here from the audience. And Dr. Della Torre, I'm going to put this your way. Number one, what is double vision? And the question is, how can you treat double vision? So, and let's talk about, is that something that somebody can have as a chronic condition? I know you can get it when certain trauma can happen, but in general, if you can take both of those.
Well, again, double vision, we call it diplopia, but double vision, it is when the eyes are not looking at the same thing at the same time. And the double vision, usually it's because one eye is crossed in or out, and there's multiple reasons for what that can happen. But can it be treated? Yes. And the most common, it's actually glasses that contain prisms within them. But when the double vision is too large, and glasses with prisms cannot align the eyes, then surgery is indicated, and that's the strabismus surgery.
Okay.
So we have to take it on a case by case, basis, and then depending on the how long they've had it, then the reason behind it, then the treatment for it. But yes, there is a treatment for double vision.
Okay.
Also more acutely though, double vision can be indicative of other problems going on.
Okay.
You can get what's called nerve palsies, the nerves that control the eye. So if you develop double vision, you definitely want to get that checked right away.
Because it's not normal unless there's something else going on.
Typically not normal,
Okay,
correct.
neurological issues, etc., right?
Yep.
Correct.
Question here from the audience, has been told to seek a capsulectomy in one eye. What is it, and why might somebody need one?
So we talked before about leaving the outer shell of the original lens in place. That outer shell in approximately 50% of patients becomes cloudy after cataract surgery. And that becomes an after cataract or a posterior capsular opacity. And we take care of that very easy. We do what's called a YAG laser capsulotomy. They sit in front of a laser, it takes about 10 seconds, we shoot the cloud away. It's basically like getting a dilated examination. So,
And is that part of the eye that you can see out of?
yeah, so
Okay.
yeah, your lens is, your artificial lens is sitting in the eye, and now
Right.
it developed a little cloud behind it.
Oh,
And
I see,
using a
behind it.
laser, no pain, no anesthesia, we shoot that little cloud away. Very common after cataract surgery to need that at some point. So that's not anything at all to be scared of or worried about. It's normal.
Nicely said. Okay. Floaters. I love the word floaters. I don't want to talk about Caddyshack, but, you know, that's kind of funny if you do know that movie. What are floaters? And number one, how do they happen, and what can you do to get rid of them? So I'm Dr. Della Torre.
Yeah, so the floaters is something that comes with time. So it's
Okay.
part of getting wiser, and you earn those floaters with time. And the gel that is inside the eye is called the vitreous. It forms these little opacities, and when the light comes into the eye, hits the opacities, they form shadows in your retina, and that's what you see as floaters. So the floater is nothing but a shadow that you see. And the floaters come in different shapes and sizes, and they come in at different times during your life. Floaters are typically benign, and there's nothing to do for them. We observe them. Some patients drives them nuts, and we try to encourage them to just be patient. Tends to go away. We cannot promise when it's going to go away, but there are patients that are absolutely bothered by them, and then we refer them to a retina specialist that can look into the eye and see if their floaters are candidate for any further treatment.
Okay.
Yeah. One thing, if I can add to that,
Yes,
again, you
Dr.
start to
Ahmed?
develop floaters, another reason you should go get an eye exam. Because floaters can be indicative. There could be other changes that came along with those floaters, so you need to get dilated to get checked. Things to watch out for, we could call them retinal detachment warnings.
That's exactly what I was
saw
going to
you
ask
wrote
about.
that down.
Yeah.
So, you know, retinal detachment is when the retina, the back surface of the eye, can start to fall off from the eye. That's bad. You don't want that to happen. And floaters can sometimes be the first sign of that. Increasing floaters, flashing lights, or most importantly, any sort of a change in your side vision, you want to get seen by, and you want to get a comprehensive eye exam, preferably within 24 hours.
Okay.
Don't go to the emergency room. It's one place where the emergency room really can't do much. They're going to
Right.
just send you out to the ophthalmologist afterwards. So, you know, make sure that you call us or call your eye doctor of choice and get it examined if you have any of those symptoms.
Again, 267-2020. Tell me how a detached retina can happen. Like, is there something, can it happen during a sport? I feel like I've heard that somebody can get hit in the head or somehow. How do they occur?
So it can be related to trauma,
Okay.
but sometimes it can just happen.
And that's what I've heard as well. So
Correct.
that's the part that I'm confused about.
And sometimes there's precursors to it.
Okay.
So you can have little holes or little tears in the periphery, the back part of the eye, but off to the side. And that's where a dilated eye examination is important, especially people who are nearsighted. What Dr. Della Torre talked about before, myopia. So your eye's a little bit longer, you're at higher risk of that. We do an exam, we see you have a little hole or a little tear. That can be treated with a laser before it gets worse and develops into a retinal detachment.
Okay.
So
Goodness
the
gracious.
main
Yes.
risk factors for retinal detachment is being nearsighted, having floaters, having trauma to the eye, or having eye surgery. And those are cumulative. So if you
Okay.
are nearsighted and you play sports and you get elbowed in the eye, that's two risk factors that you definitely want to have somebody examine you. If you're nearsighted and you have a new onset of a floater, those are two risk factors you want to have somebody take a look. You had cataract surgery and now you have floaters that develop after. You want to have somebody take a look. So those are the four main risk factors, and they can be cumulative, so it increases the risk.
Bottom
of
line is
detachment.
don't wait, right? You want to get
Exactly.
this taken care of immediately. We only have about 3 minutes, and I'm going to spell this. 14-year-old had SJORGEN. syndrome? Do you know what is that?
It's one rheumatologic condition that can cause severe dry eyes.
Ah, okay.
And so it's typically co-managed with ophthalmology and a rheumatologist, and requires not only a treatment in the eyes but also systemic treatment with a rheumatologist to treat the systemic condition that is causing it, and it definitely can affect the eyes by causing severe dryness.
Okay, and to give you a plug, Dr. Ellman, I think I read it as 14. I think that's probably a 5 because it said had cataract surgery. So again, there's just all kinds of candidates for cataract surgery. Wants to know if the cataract may come back in the future. And that's always a maybe?
No, once the cataract is gone, it's gone.
Once it's gone, it's gone.
Yeah, you could get the after cataract we talked about, the posterior capsular opacity, and then once that's gone, it's usually gone. So typically 1 cataract surgery per life, and then 1 eye capsulotomy typically per life.
Okay, and then here's the question she's asking. Does she need to keep her eye drops? I'm not sure what those are for, but since, yes, Dr. De La Torre?
Well, in El Paso, with our dry environment, low humidity, it's always good to have lubricant drops. And I always joke to the patients that no Visine and no manzanilla. And those are the two gold...
No manzanilla, as in chamomile tea?
Chamomile tea, yeah. Those are the two gold drops here in El Paso, and we want to encourage lubricant eye drops. It's always good to have them around.
Okay.
And whenever you feel sandy, gritty, tired sensation in our environment, that's dry eye, lubricant drops.
So I should not take the red eye drops if I'm having...
Good to know. We're not fans of those.
Good to know. Really quick, your joke about the cross-eyed teacher. Quick.
Okay, why did the cross-eyed teacher go to see her eye doctor?
Why?
She couldn't control her pupils.
Bump. I love it. Okay, so here we go. Question. All questions are done. Southwest Eye Institute was our show this evening. The phone number is 267-2020. Facebook, Southwest Eye. This has been, again, the Southwest Eye Institute. This is the El Paso physician. We are about to count down. You can watch the show once again on kcostv.org, also on the El Paso County Medical Society site, and that is epcms.com. And you can just find the El Paso physician logo. You guys are going to hear all about this tomorrow, and we really want you back because I have a lot more questions. So you've been watching the El Paso physician. Good night.